This talk may be a little bit polarizing after speaking to a few of you because there are going to be some pictures and videos that may not be that great after lunch, but I think we'll get through it together. So, Robi Maamari, I'm one of the oculoplastic surgeons at WashU. I also have some financial disclosures. I'm a clinical trial investigator for Horizon, Sling, and Viridian, not really related to this talk at all. So the objective of this is to introduce some common eyelid surgeries that address some of the symptoms that are associated with blepharospasm. We'll also discuss some of the indications, the approaches for surgery, the techniques, go over some videos, and the benefits of these surgeries as well. So, the most common upper eyelid surgeries that are relevant to this, let's define them. So, hooding due to excess tissue, that being either skin, sometimes muscle, sometimes fat. Typically do an upper eyelid blepharoplasty for that. We call it usually dramatic chalasis, being excess skin. And then blockage caused by drooping of the actual eyelid margin, kind of what's happening now after lunch, our eyes are kind of drooping down. That's a ptosis surgery. And that's to address the actual, where the lash line is, that being low. So there's two different surgeries kind of addressing a similar problem, but there's different approaches to them. So looking at this, ptosis or blepharoplasty, what's indicated? So if you look at the patient on the left, you can see that the lid margin where the lashes are, that's low on the left, while looking at the right, you can see that the patient has a pretty high lash line, there's just skin hanging over. So if you look at the eyelid margin position, it's low on the left, and then it's relatively normal on the right. Now if we're looking at the upper eyelid tissue, that on the left is moderately normal, and then on the right, there's definitely some excess tissue that's hanging over. And that's how we differentiate what needs to be done between those two. Oftentimes we're doing both, for ptosis where we're removing skin and we're lifting the lids, but for the sake of this, let's kind of differentiate these as ptosis or dramatic chalasis. And if you look at the results, so on the left you can see that patient had a ptosis repair, where the lid margin itself, does this actually, one sec. Yes, perfect. So if you look, the lid margin itself here, that's been raised where now you can see that light reflection through the pupil. And we've got a good result with that, that's relatively symmetric. And then if you look at the dramatic chalasis, the excess skin, this excess skin here has been removed so that you can actually see the upper eyelid margin and the lash line on both sides. And that's no longer blocking vision. So let's get into more of the details of this. So with an upper blepharoplasty, we're actually removing excess skin, the orbicularis, and the orbital fat. So here you can see the skin is removed. Here's the orbicularis muscle, and then you have the fat and the septum right here, and the fat behind that can be pooching forward. The advantage of this is this may be performed alongside with a myectomy surgery, where you're making an upper eyelid incision, which I'll show, and that way you can actually access the orbicularis muscle and remove more if you need to. If there's skin hanging over, you can remove some, but typically with myectomies, you're usually sparing as much skin as possible, unless there's a tremendous excess. That being said, if you're having an upper eyelid blepharoplasty, I know this is kind of contradicting what Dr. Holds is saying, but if you're having someone do a blepharoplasty for excess skin, with blepharospasm, it may make sense to be a little bit more aggressive with muscle removal. Ptosis repair is a little bit different in that there's the lid margin that's being elevated. So if you look with ptosis repair, we're taking this lid margin here and we're actually bringing that up. And there's three common approaches for this. So levator advancement surgery, where we're actually shortening this muscle here, which is the levator muscle in the aponeurosis, which is the connective tissue portion of it. We're shortening this to help bring the lid up. There's a Mueller muscle resection, which is a different muscle that's, if any of you have used upneek, that's the muscle that's activated by upneek. That's this muscle right here, the superior tarsal muscle or the Mueller's muscle. That's shortened here to help bring the lid up. And then the final approach is a Frontalis sling, where we're actually lifting the lid by tethering it with a sling that goes directly to the brows. So that would be attaching the lid here through a sling mechanism to the brow up there. So let's talk a little bit more about levator advancement surgery. So this surgery, kind of going through the steps, you'll make an incision in the upper eyelid crease. You'll open that up. You can or potentially remove some of the orbicularis muscle if indicated. And then you expose the levator muscle or the aponeurosis attached to the levator muscle, which is then, if you look a little bit, so right below there you can see the tarsus, which is that plate on the back side of the lid, or if you flip the lid over you can see that plate. That's what you actually suture the levator muscle to help anchor it and bring it further down so you can open the eyes more. So you can see here, kind of going through this cross section, here you cut through the skin orbicularis, you actually expose the levator aponeurosis, which is the levator muscle connective tissue layer, and then you actually anchor it down to the tarsus, which is that connective tissue plate, so that you get more lift. And then once you do that, you can sew everything up. And here, this is a diagram showing here the levator muscle aponeurosis. Here's the tarsus or the connective tissue plate, and you're actually passing suture through the aponeurosis and advancing it down so you can pull the lid further up and attaching it to the tarsus right there. So here's a video. Look. So I'll pause certain parts. Some people are looking away. So here we're removing the skin. And then, as you can tell, this surgeon is left-handed. This is actually Dr. Hold's operating, not me.
I was going to say, you are doing great, Robbie.
And then, so here we're removing skin, but we're removing some of the underlying muscle. And I'll pause certain portions as long as you guys are okay with it. But here, you can see that we've removed some of the orbicularis muscle, and that you can see the underlying septum and fat. And you know there is some benefit to that, and it's going to diminish some of the blink. I'm going to keep on going. And then now we're actually going to oh no. Oh. I'm not having much luck with speeding up for me.
I was going to say, I mean, I know that's pretty incredible. Dr. Maamari is getting his continuing medical education. Apparently.
We're getting there. I just happened to stop it, and then all of a sudden it started from the very beginning. This is the levator advancement. So here we have to access the levator, though. So we're removing the skin, the muscle. We're getting through the fat, and what you'll see is soon we're actually accessing where the levator is, and that's actually the levator muscle right there. It's actually, sorry, that's septum, and then right below that, we're going to expose. So this is, levator is right there. We're actually pulling that down now and exposing the surface of the tarsus. And that levator muscle is what we're passing suture through right here and anchoring that further down so you can get more lid lift and more opening. And you know, the important thing with this is you have to adjust it. These patients are awake. They're awake and they're you know, well, we need them. We need patients awake so that we can see how the height looks. Otherwise, contour can be irregular and we would not get the contour we want. So we adjust the contour based off of them opening their eyes, closing, seeing how things look, and we make adjustments based off of that. And the reason why we're flipping the lid is because we want to make sure that there's no suture that's rubbing on the backside of the lid, which could be irritating the cornea. Yes? Correct. Yes, we do. Different surgeons have different approaches. We tend to do both at the same time, and this kind of comes back down to insurance reasons. Because the second side, you're getting paid half as much for when you're doing the other side. But if I were a patient, I'd want both sides done at the same time, and it's probably easier to get symmetric contour if you're working on both sides at the same time. Oh, so this is in the operating room. So let me kind of backtrack. This is in the operating room. They do get some IV sedation in the beginning, just so we can numb them up. But then they're kind of comfortable and awake. There's some metal shields in the eyes blocking the light, so they're comfortable. We're usually talking, having a good time. Conversations are different depending on what OR you're in. You'll hear about history in Dr. Holtz's OR, other topics in our OR. But so at the end, you can close everything up, and then the nice thing with this surgery is everything's hidden in the crease of the upper eyelid, and you can see where the incision is. With that closure, we get a nice hidden scar. For a Mueller muscle resection or MMCR, that's shortening Mueller's muscle, which is this muscle right here. So this is more indicated for mild to moderate ptosis. And with this, there's no skin incisions made. Everything's done on the backside lid where you flip the lid over. One thing with this is because we're not making these skin incisions, there is no, you really can't get the orbicularis muscle for a additional myectomy surgery. So here you can see that the lid's flipped over. This is the edge of the tarsus. This is the conjunctiva with the underlying Mueller's muscle right here. And this is it clamped. You actually clamp it so you can plicate it or shorten that muscle. And because you guys were so thrilled with the first video, let's...
Doctor, are these typically an outpatient surgery?
Correct, yeah. So this is outpatient surgery. An upper eyelid ptosis repair for both sides typically takes about 45 minutes. This internal ptosis repair can be as short as 10 minutes, 5-10 minutes. We'll go over that. So with this, if you look, we'll actually use something to flip the lid over, and we'll loosen up that tissue under there. We'll make measurements. There's a nomogram that we follow, kind of for how much lift we want. There's a certain amount of tissue to remove, and it's usually about 4 millimeters for every 1 millimeter of lift. So we'll make some markings, and then we'll actually pull on the tissue, kind of let it fold over itself, and then you can put the clamp on there so that you can plicate it, and then we'll pass some suture through there in a sec. And then we'll pass the suture through, that allowing us to kind of pass the suture through right below where the clamp is. And what we're grabbing is the Mueller's muscle, going to be trying to avoid the majority of the fovea muscle. And then you'll see a couple more passes. We'll actually pass this. So this suture is basically connecting both ends together so that whenever you cut and plicate this muscle like we're doing right now, those two ends are together, and that's shortening that muscle, and everything's tied up. And this surgery truly does take about 5 to 10 minutes. The camera? Oh, so the reason why Hold was operating was because I was holding the camera, not scrubbed in. The camera? Oh, it's not on the field. It's kind of above, hanging over. And then, so the last approach is a frontalis sling surgery. So this is where you couple the upper eyelid to the forehead muscle or the frontalis muscle, and you can use a variety of slings, some autologous tissue, including fascia from the thigh. You can also use things like Gore-Tex. You can use polyester. As well as slings made from different types of suture. This is a common surgery for very severe ptosis, usually more commonly used in congenital ptosis, kind of from birth. But this is something that can be considered for eyelid apraxia, and we'll talk a little bit more about that as well. So, with this surgery, similar to the external ptosis repair, you make an incision in the upper eyelid crease. You'll expose the tarsus, and that will be your fixation point, kind of right here. And then you'll use your sling material, and then pass that through, and actually anchor that to the tarsus right here. And then in the next steps, you'll see that we'll pass the sling through the upper eyelid through the rim up here, and externalize that through the brow, and then we'll pass it one more time, and that's why it's considered a pentagonal, so that from the lid to right above the brow, and then, sorry, I thought I had to, through the lid, and it'll pass under the skin through the rim of the upper socket, and then that's then externalized and then passed one more time, and then you actually tie it up here to make a nice pentagon shape. And that's important for getting a good contour. Couple kind of points. We would want to avoid aggressive orbicularis resection in this surgery because the sling, particularly if it's made from a exogenous or foreign material, that may risk exposure of that sling material. And then this is a surgery where lag of thalamus or incomplete closure is very common, and that's something we have to be careful with. So this is a study that I found very interesting. So it's the use of a Gore-Tex sling for patients with blepharospasm with eyelid apraxia, and what effect it had on the dose of Botox. So it's a small study. It was 5 patients, 10 eyelids. They used a Frontalis sling made out of a Gore-Tex suture material. And the interesting thing that they found was, pre versus post Botox treatment, they actually did have a reduction in the dose of Botox that was necessary, and a slight increase, not significant, in the interval of Botox. So it was, you can get less dose of Botox after the sling with a slightly longer interval of time. When I saw this, I was a little suspicious, but the location they kind of divided between the lower lid injection site, upper lid injection site, and then the corrugators. I thought more likely than not it was going to be a decrease in the corrugators, but it ended up being that they had a more significant decrease in the upper eyelid injection dose, which I thought was interesting. It makes a little bit of sense since you're forcing your eyes closed, and if the eyes are open with a sling, you need less of the Botox there. But this is something that I found interesting, and I think is worth considering if someone has true apraxia, not unable to open the eyes, and ptosis as a result. So this may help lift the lids. So in terms of expectations, swelling and bruising, usually with those surgeries, about half of the swelling and bruising is improved by the end of the second week. It can be 2 to 3 months for the full swelling and bruising. Quite honestly, by 4 to 6 weeks, 90% of the swelling and bruising is gone. Lag of thalamus for incomplete closure, that's really significant with the Frontalis sling. It's going to be difficult to close the eyes at first, and as a result, you have to do frequent lubrication, a lot of ointment, and things are going to be blurry. There's a high risk for corneal abrasions and all that. Less of a risk with levator advancements or Mueller resections. And then with the Frontalis sling in particular, since we're passing a needle through the rim, there's always a risk of some forehead numbness if you do nick the supraorbital nerve that helps with forehead sensation. Contour asymmetry is a risk with all these procedures, but kind of just summarizing things. The big thing is a lag of thalamus with the Frontalis sling, and then the levator advancements for pretty severe ptosis, along with the Frontalis sling. The Mueller resections for a mild ptosis, and then all of these can have some contour irregularities. The nice advantage of a blepharoplasty is that you can remove the excess skin as well as the muscle, while with some of these, that's less of an option. All right, lower eyelid surgeries. With this, so the most common lower eyelid surgeries are, the lower eyelid turning out, because of laxity, causing some watering. That's an ectropion, and that's repaired with an ectropion repair. and then the lower eyelid turning in, or the lashes kind of turning in, rubbing on the eye, that's an entropion, which is repaired with the entropion repair. And here, we'll talk more about the anatomy, but the important thing to note is that the tarsus is the support structure of the lower lid. There are some muscles that are pulling back, creating a vector that's pulling the lid back. That's counteracting the orbicularis, which is trying to kind of cause it to turn in. So there's a balance between the lower lid retractors trying to pull the lid out and the orbicularis helping keep the lid up. And if you look at these patients, so these all have a kind of a common theme. There's a lot of laxity, and this lid's turned down. You can see that when you pull this lid down, there's a lot of laxity where you can distract it pretty far away from the eyeball. And then here, because of the laxity, this whole tarsus is turned out, and you can see that pink tissue, the conjunctiva, which shouldn't be exposed, is exposed. This leads to watering for a couple reasons. The eye is exposed and it's going to be irritated, but also the punctum, which is what collects the tears, or the tear drainage system, is right over here. And if it's turned out, it's like a gutter in the wrong position. It's not going to collect any of the tears. So the lateral tarsal strip is kind of the mainstay for fixing this, and this is kind of one of the surgeries that Rick Anderson really solidified, as Dr. Holmes talked about earlier. So that's a surgery where you actually make a cut on the outside corner. Don't worry, I won't show you pictures. But you'll make a cut on the outside corner. You'll expose the outside corner of the lower lid tendon. You'll actually attach this to the outside rim. That way you're shortening the lower lid and tightening it, and then you'll sew that closed. Other options, you can actually wedge some of the eyelid out, and that shortens the lower eyelid, helping it rest on the eyeball and oppose the globe better. One other thing is, if the punctum or the tear duct is turned out, you can do a surgery where you make a little kind of ellipse of tissue in this region, right below where the tear duct is on the inside corner, and bring that together, helping turn the eyelid in. For entropion, this is kind of where the money is. So here, these are the lower lid retractors, and those are pulling on the lower lid, trying to keep it from. It's a lot of vectors where you're pulling on the bottom of it, and by pulling on the bottom of that tarsus, you're opposing the orbicularis, which is trying to cause it to turn in. So a lot of times what happens is this area that's in the green, if these muscles stretch, then the orbicularis kind of overacts, and it causes the lid to turn in and the lashes to turn in. So you can see here, with the torn capsule, with the torn retractors, we'll say, this causes the lid to turn in, and as a result, you're going to have the lashes rubbing on the surface of the eye. So looking here, with the lid turned in, you can see the lashes are on the eye, it's causing a red, irritated eye. There's two mechanisms to repair this. One is horizontal tightening, kind of we're using the lateral tarsal strip that we did before, that we saw before with the ectropion repair. This re-anchors the outside corner to the rim. But the other approaches, and this is beneficial for if you have a lot of orbicularis overaction, is you can make an incision right below the lash line, remove some of this, a little bit of the skin, but also remove some of the orbicularis muscle there, as well as reattach that shortened or the stretched out retractor muscles just to reestablish those vectors. And by doing so, you actually can decrease the lid turning in, but also remove some of that orbicularis that may be overacting in the lower lid. And along that theme, using that lower lid incision, you can use that same incision as a means of extending it into a myectomy, if indicated. So, in summary, there are several surgical interventions that can be used to address eyelid malpositions associated with blepharospasm. And then these techniques can safely address a lot of the symptoms, including decreased peripheral vision as well as eyelid irritation. Happy to take any questions.
When you're making the incision in the eyelid, how do you keep from going too deep into the orbit of my eye?
Gently. No. You're aware of, so you typically want to incise through the skin, A lot of times when you inject the local anesthetic, that kind of puffs things up as well. But in general, you're just visualizing, you're keeping things on stretch. That way you can see how deep you're actually cutting. Our blades themselves are they're smaller blades than a typical surgical blade. That way it has less height, so you can see what the depth is. But that's obviously a concern, especially in a training institution, when you're training someone that's less familiar. But it's it's easier to stay superficial than you think.
So for the primary ones involved in blepharospasm, if they have a good result in the first year, what is their typical answer 5 years after the surgery? Do they rate it still the same, or starting to burn it off, or redo?
Are you saying with like Ptosis repair or those types of surgeries?
Yeah, some of the more popular ones.
Yeah, for the most part, I'd say 5 to 10 years they're doing fine. In general, a lot of patients we see, particularly 50s and beyond, 15 to 20 years afterwards, they're needing revisions anyways, just because we're just resetting the clock with the excess skin. But in general, the year or two that I've really paid attention to following their post-surgical result, they've been good.